Let's discuss insertion of an endotracheal tube via laryngoscopy today. Going to start off with showing you a Macintosh blade and a Miller blade. So the blade with the curved end, you want to make sure you got a light, it's bright and it's tight. These have the fiber optic lights in them, so they're going to be pretty bright anyway. There's not really a bulb that you've got to worry with making sure that it's tight. But nonetheless, you do want to make sure that your light source is bright. These are left-handed scopes, so you'll hold them in the left hand. Miller blade, Macintosh blade. The Macintosh blade has a curve on it. Miller blade is straight. The difference is going to be anatomical placement once you enter the mouth. As you enter the mouth, you're going to enter to the right of the mouth and sweep left. Place the Macintosh blade into the vallecula space. That pressing into there will lift the epiglottis so you can visualize the vocal cords. With the Miller blade, you'll physically lift the epiglottis with this so that you can visualize the vocal cords. This is a left-handed scope. Do make sure that, I always tell people to make sure that they find where the ceiling meets the wall and lift toward that as opposed to rocking back. Also, I tell people if they'll kind of choke their grip up a little bit on the actual laryngoscope itself, that'll kind of help you give better control where you want to go, and you can lift forward as opposed to if you're holding it up here, you may have a tendency to want to pretend like you're in Vegas and rock back a little bit on a slot machine. And you don't want to do that because you'll break teeth, and you could aspirate the teeth, and then you've got to have a bronchoscopy, go in and get that. So that's the old school method of doing that. You may eventually graduate to the Glidescope, which is what I'm going to show you here. So with the Glidescope, you've got the video screen, you've got the actual handle itself that'll be utilized. There's also the Glidescope stylet that will be used with the endotracheal tube. I've checked this cuff to make sure that the cuff works appropriately, and it does. And I'll utilize this to actually access the trachea here shortly. So just to kind of recap with what I'm looking at here. So if you had the Miller or the Macintosh blade, for this case, I'm gonna have the Miller blade, you actually insert right, sweep left, and then you're gonna pick up. Now this is my right hand. It's a left-handed scope, but I've got the Glidescope camera in my left hand. So go in right, sweep left, you'll go in, and don't rock back. You don't want to break teeth, so everything's got to lift forward as you're doing that. So it takes a little bit of upper arm strength to be able to do the old school laryngoscopy. You may find that you enjoy the Glidescope quite a bit better. So with the Glidescope, what we're going to do is we're going to come midline to the into the mouth. So you see the nose and stuff here. You see that upper lip, lower lip here. So we're going to follow the tongue. We'll follow the tongue down, and you can see the teeth. You also see the uvula there. And now once I get toward the base of the tongue, there's that epiglottic structure I was telling you about. So right now I'm in the vallecular space. As I press on that, it lifts the vallecula to kind of open up to the vocal cords. And if I go far enough, there are those vocal cords. So you can see the vocal cords. You see the arytenoid cartilages to the bottom. So these little white folds are your vocal cords. This is the epiglottic structure that we're talking about. If I advance a little bit deeper, you can see the esophagus. So you want to stay away from the esophagus, because if you put air down the esophagus, it's going to come back out, and any contents that's in the stomach is going to come up with it. And then that poses the patient at a risk for aspiration. So it could go down into the lungs, cause the patient having aspiration pneumonia, and that's not advantageous. So once you are able to establish the view that you want, now you're going to take with your right hand and hold the endotracheal tube just like a hockey stick, if you will. And you're going to insert to the right of that tube, or to the right of the scope rather, and you can watch that endotracheal tube come into view, and then you'll push that tube through those vocal cords until you've passed the cuff through. Now you'll pull the scope out. We're going to hold and pull the stylet out of the endotracheal tube. I've got a syringe that I'll inflate the cuff with. Once that cuff is inflated, now you're going to apply your colorimetric CO2 device, all the while holding on and maintaining your endotracheal tube. Place the colorimetric CO2 device here. You're going to assess for positive color change. We will also listen to bilateral and equal breath sounds, and then order a chest x-ray so that you can view that radiopaque line on the endotracheal tube and find that it terminates about 3 to 5 centimeters above the level of the carina as far as the MBRC is concerned. In the hospital, you may hear 2 to 4 centimeters above the level of the carina, but that's essentially where you want the tip of that endotracheal tube to be. Because remember, if you're too deep with that endotracheal tube, based upon the way that the anatomy of your bronchi work, you're likely going to insert that into the right main stem bronchus. So there's endotracheal intubation and a few notes and tips to go along with it. Thank you for your time.